how do we act and when do we act on the results of the validation is something that we'll come across as I progress. So I've had a long-standing interest in model validation, probably starting with my PhD, where I tried to validate my models as best as possible, but probably my interest has intensified since joining the economic subcommittee of the Pharmaceutical Benefits Advisory Committee here in Australia, where we review lots of models that are submitted to support the value of new pharmaceuticals, and we virtually never see any attempt at validation. And so I'm really trying to push for more model validation through the PBAC, and as you're probably aware, there are a new set of guidelines coming out very soon, and whilst they may not be as strong on model validation as I would perhaps like, there is some movements in that direction. So with that in mind, what I thought I'd just start by kind of working down. So when I think about validation, there's basically two top-level questions that we're thinking about. The first one is really, are we building the right model? And so that obviously relates to things like the structure of the model, the assumptions inherent in that structure. And once we've defined what we hope is the right model, are we building the model right? And here I'm not just talking about implementing and the code, and etc., but I'm also talking about the parameterization. And so if we can get both of those two issues right, we'll hopefully have more valid models and more valid estimates of cost effectiveness and value. But I think it's probably also important to say at this stage that validation isn't likely to be a solve-all. So we're not going to get to a point where we can say with certainty that models we developed are right as an objective fact. We're more aiming to improve our confidence, which is more of a subjective measure of the rightness of our models. And I guess the little cartoon there is people who've been through validation processes will be familiar with this thought, certainly from the person. Whether the computer's thinking the same thing, I don't know. Probably. So that's the kind of top-level questions that we might think about, and then to address those top-level questions, we've got these different forms of validation, and you see there's a lot of different terms that are used to describe what are essentially the same thing. So, for the first level of validation, what most people, I think, refer to as face validation has also been described as descriptive or first-order validation. Then we move into, and so I'm going to this is just the outline really, I'm going to go through each of these forms in a bit more detail. So internal validation or second-order validation is sometimes split, or should be split actually, because these verification and predicting internal outputs are very different forms of validation. So really there are two levels within that category. Then perhaps what most people think of when we think of, well, maybe I'm talking about myself, when I think of validation, the first thing I think about is external validation, and that's where we're comparing our model outputs to external data. And I've put calibration in question marks there because calibration is in a way is a kind of an alternative approach to some of these forms of validation, where we're not comparing predicted values, but we're actually fitting values so that the model predicts our observed outputs. But I won't talk about calibration in this talk any further because it really is a subject on its own. And then we've got cross-model validation, which, as we'll see, is the most common form. And then finally we've got predictive validation, which is the rarest form because it's the most difficult form of validation to undertake. So just to give an outline of where we're at, or where we were at in 2013, from this review that we undertook of published model-based cost-effectiveness analyses in cardiovascular disease, you can see the relatively low prevalence of different forms of validation across those 81 studies. As I say, cross-model validation was the most common. Of half of the studies made some reference to cross-model validation, whereas the other forms, less than 1 in 5 studies reported on the conduct of those different types of validation. So if we start with face validity, I think when most people think about face validation, you're thinking about the structure of the model, and does the structure make sense to experts? Does the structure have validity? But really, it's not just the structure of the model; it's the input data and the outputs. So the full process of face validity is an ongoing process through the development of the model. So that's what we talk about, iterative process, both within each of these phases. So structure, confirming face validity may be iterative within itself, but to confirm face validity across the whole process, we have to keep going back to the experts at different stages. And so obviously our intention here is to improve the credibility of the model and acceptance by stakeholders. And so yeah, so this little cartoon at the bottom is really relating to the input data and especially extrapolation methods. And certainly in the models we see through the p-back, there's quite a few models we see where you think, well, if you'd have just looked at the data you're putting into the model, you may have taken a different approach and got to a better endpoint sooner, rather than having to go through the whole process of external review of the model. But in terms of assessing face validity, we can have subjective, well, we're obviously using the subjective judgment of experts, which can be on a formal basis, so using Likert scales, but most commonly it's an informal assessment. I think that's appropriate. It's, if you measure something on a scale, clearly you can see whether the validity of the model or the data or the outputs is improving if you're going through an iterative process, but at the end of the day you've got to get to a point where you say, well, is the model, is the data, are the outputs sufficiently valid, which is really the point where we want to get to. So in our review, we found, as we might expect, that well, firstly we saw that face validity was very rarely mentioned. I think it was 7% of studies made any reference to face validity, so it was the least reported form. And where it was reported, it was limited to validation of the model structure and the assumptions, and in all cases it was an informal assessment. So the kind of statement that you would see would be something like, the events included in the model were in agreement with expert advice. So there's not a whole amount of detail on what process was used to determine or to assess face validity. But we have found some good examples in the literature of the application of methods to assess face validity. So this is what we might think of as a gold standard for assessing the validity of the model structure. So again, this study only looked at structure without going forward to validate the data inputs or the outputs. But for a childhood asthma prevention model, they assembled a whole group of relevant clinical but also methodological experts. So you've got your generalists, the GPs, your specialists, then you've got your epidemiologists and HTA experts who are providing complementary advice and informed views on the model structure. And they went through an iterative process of three meetings, face-to-face meetings that were used to define and then refine the structure until they got to a point where the model structure and the assumptions were accepted by all of the experts. So you can see that that kind of process certainly adds significant time to the model development process, and so it's not going to be appropriate in all circumstances, but where it's possible, where the resources and the time facilitate it, then it's clearly a useful process to go through. internal validation or validity, so we start by thinking about verification. So this is essentially saying, well, we've built the model. Are there any bugs? Is the model producing outputs that we'd expect given the inputs that are going into the model? And so the ideal approach to this form of validation or verification is it can involve the implementation of multiple versions of the same model, preferably by separate analysts, and maybe also using, or if you're the same analyst, then maybe implementing in different software. So if we're doing state transition models, we can use Excel, we can use Triage to implement our models. So that, I guess, this, in terms of ranking, those would be the first two options. If we can't do that, or even in addition, we can have an external review of the implementation of the model code, and all of these things can really help to identify bugs and increase confidence that there aren't any bugs. I mean, that's really where we're aiming for. To give an example, I've drawn one from my PhD studies. I probably the models I developed for my PhD are probably the most validated models that I've ever done. It's been downhill ever since, really. But that's primarily because when you're doing a PhD, you've got a lot of time, and once you're in the real world, you've got less time. So to verify my breast cancer model in my PhD, I implemented these sequential stages of verification. So I wasn't able to get external review. I didn't implement in two different forms of software, but I went through a kind of formal checklist approach where I looked at whether the model was producing our expected outputs given a predictable set of inputs, tested the movement of outputs to changes in the input data, and also tested to what input values that should give nonsensical or illogical outputs. And then this, well, having said that, I was using different modeling techniques. I was using cohort-based state transition models and discrete event simulation, but that really wasn't able to inform the verification because we were getting different results due to the characteristics of the different modeling approaches. But I guess it provided some additional evidence on verification. Internal validity, internal outputs, there should be some text here, there we go, is where we have a data source that we're using to estimate our input parameters, but that same data source is providing some output data, so data on outputs from the model. So this is a simple example. If we're building a cancer model, we might use the data on the left, the recurrence data, to estimate the probability of recurrence over time, but the data on the right is describing mortality, and clearly overall survival or overall mortality is not an input to the model, so we can compare our model outputs for mortality with the observed data from the same source that we derived our recurrence probabilities. In this case, where the mortality isn't solely defined by the probability of recurrence, i.e. solely defined by the data from this data source, we wouldn't expect an exact match because our probabilities of mortality in the absence of recurrence and probability of mortality following recurrence were taken from other data sources. So it does leave the question open of, well, just how closely would we expect our model to predict the observed mortality data. So that clearly brings us to the issue of when to act. And so we've got a couple of examples from the literature where they've reported the results of their internal validation analyses. And so the first one here is a model that we'll return to because they did a very thorough job of validating the model was a cost-effectiveness model looking at the comparing screening for abdominal aortic aneurysms to no screening. And so it used the chi-squared tests to compare observed and predicted numbers of events for various outputs from the model. And so you can see just from these two that for emergency operations, very close exact predictions, so 62 and 62, p-value of 1. But for elective operations, we've got the observed value was 100, but the model was only predicting 83, and the p-value was just outside that typical threshold of 0.05. And so as a result, the modelers, the analysts, took that as well, certainly as not requiring any modifications to the model. They were happy with that level of accuracy, and so I guess I imagine that they tried to improve the predictions, but maybe within the context of the model they defined weren't able to, without maybe reducing the accuracy of predictions of other outputs, and so they took that as their best model and went with that, which I think, as you will see in a minute, this was a very thorough process, and it's probably reasonable in this circumstance. The second example was a cardiovascular model. Instead of looking at chi-squared statistics, they just compared absolute differences between model outputs and observed outputs, and their reporting of this was that the model underestimated the absolute reduction of the risk of non-fatal infarction with clopidogrel by 1%. And again, on the basis of this finding, no action was taken to improve the predictions of the model. But to me, an absolute difference in effect, this is an absolute difference in treatment effect of 1%, seems quite a significant an amount, and obviously without presenting the uncertainty and the level of precision, it's difficult to make any further judgment. But just looking at the data as presented, you would think, well, maybe some action should have been taken in that case. This is a very nice example of where action was taken. So this is another cardiovascular model. So you've just got the structure of the model on the left-hand side. On the right-hand side, it's the diamonds are the observed data, and so you can see in year 1 we've got an absolute difference in event rates between the treatments and intervention, between the intervention and control of around 5 per 1,000, which then increases to between 15 and 20 in all subsequent years. The red line is the original model predictions, which was, you can see, based on current LDL concentration levels, and you can see that it over-predicted in the first year and under-predicted in the subsequent years, although within the confidence intervals. But by going back to the model, going back to the input data and changing the way in which the event rates were estimated, so now with the blue dotted lines we're predicting on the basis of average LDL concentration over the preceding 18 months, we can see we get much closer, much more valid estimates of that difference in event rates between the parameters. So that's really, to me, illustrates the value of the validation process, in this case internal validation. So this was the heart protection study. So moving on to external, or sometimes labeled independent validation. So this, as I've said, is where the model outputs are compared with output data, relevant output data from a source that wasn't used to inform our input parameters. And I would say, from my experience, some form of external validation is generally feasible. You can argue about the value of some forms of external validation, but some form is generally feasible, and most commonly it's around survival. Because survival is never a direct input to the model, so it's generally feasible to obtain some relevant data describing survival in your control population at least, against which you can undertake some form of external validation. That said, of course, it's difficult to externally validate against all aspects of the model, so in particular it's often not possible to validate outputs or outcomes for the intervention, primarily because the intervention is generally new, so there hasn't been the time to collect or to report on external data on the intervention. So most commonly you're validating the control arm or the comparator arm within your model. And secondly, it's unusual to be able to validate your cost and quality outputs because they're difficult or they're not generally observed. I mean, this may change. We hope it will change over time. Certainly in Australia we're collecting and publishing cost data more frequently, and there's talk about patient-reported outcome measures. So in the UK we've got patient-reported outcome measures around a number of different conditions, and that should provide some useful data against which models in those areas can be validated. So in terms of selecting the data, clearly the external data should be representative of the population for whom a model is being built, for whom a funding decision is being informed. And when we're looking for that data, it's a bit like the kind of a priori and post hoc analyses. We would ideally seek that data before completing the model. And generally what I do is when I'm looking for input data for the model, I'm also looking for external data that I can use to validate the model. They're going to come from similar literature searches and data searches. So I guess it's always be on the lookout for that external data. Bigger is better generally. More data sources for more model outputs, as long as the data is relevant to the model, then the more you can, the more aspects of the model you can validate, the better. And don't always look for kind of final model outputs. There may be process measures, intermediate measures that you're not using as an input that you can use as a measure for external validation. And so some common data sources, population statistics, routine healthcare data and registries are those data sources that I've found most useful when looking for validation data sources. So returning to my earlier study for my PhD, so really tried hard to validate our breast cancer model using external data, and so this is the data that we identified. So we looked at costs, and so we validated. So this was a model that was describing costs and effects in patients with early breast cancer, but we could obviously adapt the model to collect data once patients had experienced different events. And so we've got 4-year cost data and we've got lifetime cost data from different data sources. So the first 4-year cost data was this was in the UK, and it was UK data, but unfortunately it was only on 13 patients. So you can see there's some difference in our estimates, but 13 patients, that's probably not a significant difference. The lifetime costs were from Canada, and this I felt was obviously converted using the appropriate methods, and got we underestimated. But then you go back to the data and you kind of say, well, why might we be underestimating? And one reason was that the Canadian data included radiotherapy costs and we didn't include those, and so I think that was a reasonable comparison. And then looking at mean survival, we were overestimating mean survival at 12 years. but we were pretty close, within 1 year of the observed data, and we kind of thought, well, you know, the data that we're using in the model probably represents slightly improved treatments, and so you'd expect, if anything, for our model to overpredict, which it did. So our conclusions were that, you know, given the uncertainties and the you know, imperfections of the external data, it was difficult to refute the validity of the model. But I guess, you know, you could turn that around and say, well, yeah, it's difficult to refute, but does it actually provide much positive evidence of model validity? And, you know, I'd like to think it does, but others might disagree. So returning to Kim and Thompson, so they did internal validation, then they did external validation, and so here again is an area in which they acted. So there's the non-smooth line is the observed data, and the grey is the confidence interval around that observed data. And so you can see the model 1 was underpredicting deaths from aneurysms, and so they defined model 3, and you'll see why it's model 3 in a minute. And that model clearly predicts aneurysm deaths much more accurately. But they also used a whole range of model outputs to establish or to test external validity. And you see the Chichester column is the observed data. Model 1 was their original data, and so you can see that the p-values, quite a few of the p-values are very low, indicating that there's significant differences between the observed and the predicted values. And so model 3 is what they define as their best fitting model in relation to the external data. So you can see there's still some significant differences, for example, in incidentally detected aneurysms leading to elective operations. And yeah, some of the top there in the control arm are certainly lower than 0.05 threshold, but across the range you can see that there's clearly improvements in the model's predictions. And I say we'll come back to why that was model 3 in a minute. So moving on to cross-model validation. So this is clearly where we compare our model's outputs with outputs from other models that were developed independently. And generally when you're undertaking this form of model validation, you obviously don't want to just limit your comparisons to models that were developed within your jurisdiction. You may want to compare against any model, so then you need to make some adjustments for currencies and for the year of analysis, but that's all pretty straightforward. And when you do your cross-model validation, you know, essentially you're going to come out with one of four conclusions. So you can identify models that are different, or different structures, different assumptions to your own model, and if you find the same results, then that gives you additional confidence that the results of both models are hopefully not both wrong. You can find you've got similar models with same results, and clearly that's not providing such an additional level of confidence, but it's providing some confidence that your common model structure is appropriate, because these independent analysts have come up with the same model structure independently. You can have different models and different results. Now clearly this, well, when you're getting different results, there's some more investigation to be done. So, you know, why are we getting different results? Is it perhaps that the data sources, the input values used in the two models, they were driving the differences, or is it that the structure of the model is driving the difference? And clearly, if the inputs were relevant to the time and place at which the other model was undertaken, but wouldn't be relevant to the time and place in which you're undertaking your model, that's less of a concern. But if the conclusion is that it's a real difference, then we're entering the realms of structural sensitivity analysis, or essentially develop it. Well, I guess this is all in the context of what other forms of validation have been undertaken as well. So if you've been through other forms of validation, you're confident that your model is valid from those sources, then maybe the cross-model validation is less relevant. But if you haven't, then it obviously raises issues that should be addressed. And then finally, if you've got similar models and different results, then it's really, that's I guess the worst case, where you have to hope that it's due to differences in jurisdiction-specific differences in input parameter values. So they're using values that are relevant to their jurisdiction, but wouldn't necessarily be to your jurisdiction. If not, then then I guess you have to iterate and try and find or convince yourself and the model users that your model is doing what it should be doing. So in terms of the review, as I say, it was the most commonly referred to form of model validation, but when we look at the details, we can see that the three right-hand columns are the studies where they mentioned cross-validation. So you can see in more than a third it was mentioned but not undertaken because they couldn't find any other models. And then in the third column there, we've got validation where it was undertaken, but it was just kind of a descriptive with no quantitative details provided. And then I guess the best examples are where they've undertaken it and they provided some quantitative comparisons between the models and discussed the potential reasons for those differences. So you can see that those reasons ranged from structure, which is clearly an important reason for a difference, and if the structure is driving differences in results and outputs, then that does warrant further investigation, whereas differences that are due to maybe taking a different perspective or different input prices can be used to justify no further action. So I just wanted to talk briefly about the Mount Hood challenge. Some of you may be aware of this is an annual, I think it's an annual challenge where basically the world's diabetes cost-effectiveness modelers meet up and they bring the models with them and they discuss and they compare the models, and the way in which they compare the models is by predicting outputs from a published clinical study. So in this particular year, I think it was 2013, maybe 2012, the Accord clinical trial had been published, and so the 7 different diabetes models attempted to predict the reported outcomes of the trial. And you go just picking out some important outcomes. You can see if we look at CVD mortality, which is clearly an important outcome, a lot of the models were over-predicting. So you got the IMS core and the Cardiff models were the most accurate with respect to that outcome, but then they were less accurate with respect to other outcomes. So for example, Cardiff was under-predicting non-fatal MIs and non-fatal strokes. So across the board, the model predictions were not that great. But so they obviously discussed and assessed why that was the case, and the conclusion they came to was that they found it difficult to replicate the observed study populations in their models because the models were representing certain characteristics and maybe there were other characteristics that were relevant, but also there were differences in local care pathways outside of the intervention being evaluated that influence these outcomes, and again it was difficult to replicate those aspects, and it was also difficult to estimate the individualized event risks given the characteristics that were represented in the models and also the risk factor progression. So I think in other years maybe the models have performed a bit better, but in this particular year they found it difficult to replicate the outputs. But the same paper also raises the important issue of, well, how do we actually assess what validation means, or whether a model is validated, in particular in relation to external validation. And so they put forward a proposal that appropriate statistical approaches should be defined that could be used across all models to assess correlation, and predefining limits that would be used to assess whether the model was sufficiently accurate and sufficiently precise. And so you can see they call for a consensus group with appropriate statistical expertise to advise on this issue. But certainly from my experience, I think the level of precision can vary from example to example, and is very much dependent on the validity or the relevance of the data that you're using to validate your model. So I really don't think there's a one-size-fits-all approach to defining model accuracy and precision. So the final form of validation is predictive or prospective validation. So this is where you collect data beyond the initial reporting of the model. So it's data collected subsequent to model development. You see the advantage of this is that it removes suspicion that the model was altered to fit the observed data, or that process of altering to fit the observed data is essentially calibration, which is a reasonable approach in my mind. But perhaps more importantly, it validates the model, but also it validates any funding decisions that were made on the basis of the model. So was the right or wrong funding decision made? And so ideally, well, I guess in terms of the requirements, the first one is a requirement. You need continuing data collection. You also need continuing resources or funding to undertake the predictive validation process. I guess the second one is more of an ideal, that if you're going to go to the effort of testing the predictive validity of your model, you would ideally have an ability to change the funding decision if you found that the wrong funding decision had been made originally. So the only example of predictive validation that I have come across in looking for examples, I'm sure there are others out there, was again this Kim and Thompson paper of screening for aneurysms. And so here they present the whole set, or I present the whole set of validation results. So you can see they've got internal validation, prospective validation against years 5 to 7, continued data collection, then they've got the external validation against the Chichester data. And so you can see the Model 1 was internally valid. Model 1 wasn't validated against the prospective data. Model 1 wasn't validated against the external data. Model 2 was generated in response to the prospective data, and that was found to be, well, you can see from the p-values, reasonably predictive of that prospective data. But when they applied Model 2 to the external data, the results aren't presented here, but it didn't do well at predicting that external data, and so they had to generate Model 3, which, as we've already discussed, is not is better than Model 1, but still some issues. But I guess if you look at those three forms, the internal validity is clearly important. The prospective validity is also important, and so I guess I would argue that maybe the external data, because it's of a different context, even though it's still a UK study, is maybe less relevant given the availability of the prospective data. But I did define this question. I know it's going to be difficult for you to respond, but just thinking about it, given that data or that validation data, how would you respond to the results of the internal, the external, and the prospective validation results for this screening model? And so I guess my response would be, well, ideally, we'd review model structure to inform a more complex model. And so this is what the analysts reported was, this is essentially as good as we're going to be able to do with our existing model. And the next step would be to, essentially go back to the drawing board and define a more complex model that allowed us to predict outcomes more accurately. But clearly that's an intensive approach. The other option would be to treat each of those fitted models as potentially valid and use this as part of a structural sensitivity analysis. So I think that's reasonable, but as I've said, maybe you'd put less weight on the model that was externally valid than you would on the model that was prospectively valid. But that's okay, you can do that. You can assign different weights to different model structures, and so that would be a reasonable approach, I think. And then the third option would be to advise the decision maker that the models are not valid, and they should base their decision on the observed data and their subjective opinions of the long-term costs and effects. So actually in this case, by the time you'd got to your 7-year data, it was pretty clear that the screening was cost effective. So you could actually say, well, actually in this case you could go with option 3 because the decision was pretty clear based on that data. So, but it's a nice example of a very thorough and well thought out validation process. So just to finish off, I just wanted to mention the ADVISI tool. So this is the assessment of the validation status of health economic decision models, and I'm assuming the acronym is based on the Dutch translation of that title. I'm not sure where the D comes from, but this is a very important study, and you may have seen it published recently in Pharmacoeconomics, and I wrote an accompanying editorial in praise of the tool. And so you can see the process that they went through to generate and validate the tool, I guess you could say. Yeah, so I think at the end of it, they've come up with a very useful tool that really covers all of the important components of validating cost effectiveness models. So there are essentially 13 questions that analysts are asked to respond to, and they cover the development of the conceptual model, the input data, a lot of focus on verification to reduce modeling errors, and then finally on the model outputs. So you can see that face validity appears 3 times. So as I say, I think the face validity at these different stages of the model process is important and can save time later if you, specifically with the input data. If you can get experts to agree that the data you're using has face validity, then that can resolve a lot of problems later on when you've got to kind of go back and work out why your model outputs are not predicting your observed data. So in summary, I would say that we've been talking about model validation for quite some time, but in terms of actually putting that talk into action, we haven't maybe got as far as we could have done. And the reasons for that, I think, firstly, going through that full process of model validation takes a lot of time. It can add a lot of time to the model development process, and in some cases we simply haven't got that time. If we've got a deadline to meet, you haven't got the time to undertake all of the validation steps, but I would certainly say you could prioritize and undertake some of those steps. I think maybe the journals and decision makers sometimes provide limited incentives for analysts to validate the models. So just picking on the old guidelines for PBAC in Australia, the section on validation essentially said that sponsors should consider approaches to validating the results of their modeled economic evaluations, and as a result, maybe they did consider, but then they considered not to, and so we saw as I've already said, we see very few submissions that include any form of reported model validation. You could argue that for processes such as PBAC, where models are submitted and reviewed by independent teams, independent evaluation teams, that process is a very strong form of validation, and I'd agree that the review teams do a very good job. But they review the models, they point out all the flaws, and they come to the committees, and the committees say, "Oh, we can't make a decision. It's got to go back," and so it creates delays in access to new drugs, because the models have to be revised and resubmitted, whereas if they've been through a validation process in the first place, we streamline the process. So in terms of what next, so this is a suggestion from my editorial that maybe we ought to think about defining full and rapid cost effectiveness models, where full models would be those that had been through some form of validation process, whether it would have to demonstrate that they've been through all aspects of the Vichy tool is a matter for discussion, but certainly I would be keen to see the Vichy tool used as an appendix. And the tool does say that not all questions are relevant, and I guess it's just a question, well, what's the expectation in terms of, for example, face validity? Should we expect that the face validity of the model structure of the input data of the outputs is all assessed, when going through that process involves getting experts together, finding time, presenting the data, etc. So it's clearly not going to be relevant in all conditions. And would we want to define, to maybe use the kind of derogatory term of rapid cost effectiveness models for models that didn't go through that process? I think it's an area that we can talk about, but I think in general terms there's certainly a lot of improvements in terms of model validation that we should be pushing for. So I'll stop there and take any. I hope we can discuss any of the issues that I've raised there.
Thank you, John. That was very interesting. Can you see there's a question there from Richard Edmund? Can you see that question?
No. Let me. Is it in the chat box?
Yeah.
Oh, there we go. Yeah. There's a long question. If you're looking across a wide range of intermediate and final clinical outcomes, it's probably expected that some items will be different by chance if they're independent issues. Others are likely to move together. Okay, so you're talking about correlation between your outputs. How much do you even intuitively feel that we gain by looking at multiple criteria in validation? Well, I guess I said that the more the better. So from my opinion, the more outputs we can get, the better. And I guess in the example that I gave, the aneurysm, where they had a whole range of outputs they were using, they were all from the same data source. So when they're coming from the same data source, they clearly that's a stronger data source than if you're getting estimates of model outputs from multiple data sources, where clearly the correlation is not going to be as strong. So I think it, as I kind of said at the end there, I think that's why you can't really have a pre-specified level for defining whether a model is valid or not, because it really depends on the quality of the data against which you're validating your model.
Okay, is that fine, Richard? Do you want to come back on that one?
Oh, I think I've got it. I think I've worked out how to get the volume to happen. Yep, that's fine. Thank you.
Thanks, Richard.
belatedly managed to speak. And hello.
We can hear you loud and clear.
There's another question here, John, which you won't be able to see. I would like to ask what he does when the validation throws up a statistical insignificance, but the outcome is clinically significant, and vice versa.
So, just to repeat that again. So the
question is, what do you do when the validation throws up a statistical insignificance, but the outcome is clinically significant?
Okay. Yeah. Well, I guess you generally go with the statistical significance. So I guess analogous to interpreting the results of clinical trials, that if the difference is not statistically significant, then you work on the basis that it's not a meaningful difference. But yeah.
Okay. Pasquale, did you want to come back on that at all?
No, that's fine. I see the point. I'm quite happy with that answer. Thank you.
One of the things, John, that I often have concerned about is when I get a paper, there's often no validation reported in the paper at all, and you go back and ask for some. It's very difficult to, and then it comes back and there might be 3 or 4 cursory lines. It's difficult for me to judge and know what is enough validation, what is enough discussion in the paper for it to be, for example, sent to review. I guess that's a difficult question about the minimum standards of validation.
Yeah, I mean, and that's an issue that's, I get the Mount Hood papers started to talk about, but it's not been discussed. So we had the ISPOR task force, and one of the task forces was looking at validation or model conceptualization. Well, there's a group looking at validation, and they didn't really address that issue. I mean, I guess when I'm reviewing papers, it's really just trying to get a feel for, have they made a sufficient effort to validate. I mean, things like face validity, you could argue, everyone could go through a face validation process, but because it's not dependent on finding data, well, you've got to find experts, I guess, but in theory, everyone could do that. But would you expect everyone to do that when that's clearly going to take time and resources to go through that process? Whereas for the other forms of validation, so your external validation in particular, I would like it if everyone made an effort to find data that could potentially be used to validate their models, and so then you could describe how you sought data, and if you couldn't find any, then at least it's reproducible, because you're saying, well, this is the process I went by to try and find data, and I couldn't find any data. So I think personally, again, it's going to, compared to not doing that, it's going to take some time, but I as a modeler myself, I wouldn't be against that being a criterion for publication.
What about verification? What about sort of debugging and checking things?
Yeah, I mean, that's a difficult one. I mean, clearly, like I say, the ideal would be, the model was externally reviewed or was implemented in different software. And then obviously the weaker, I mean, the most common form that when it's reported is that we tested different values and essentially what I undertook and reported. I mean, I think again, my personal perspective would be that that would be a minimum, that you at least make reference to the fact that you did that. And I think all modelers should do that. That's not a. And I think with the Advishi paper, they did a review as well, and they actually went one step further because they tried to contact the authors. And I think what they found was that for a lot of papers where they hadn't reported verification, the authors had claimed that they had actually been through that process, but they just hadn't thought to report it. So. Personally, I think it would be good if the papers, like I say, it's only a couple of sentences if that's all they've done, but just to explicitly state, we went through a formal process to verify the model.
Yeah, I think another alarming thing about that paper was the lack of response from many of the modelers when they tried to contact them. I think it was quite a low response rate.
Yes. Yeah, I noticed. Yeah, it's in the that diagram here. Yeah, you can see them. Yeah, so for the Delphi, so you got 426 invitations and 31 answers. So yeah, I mean, you'd think modelers might be more responsive, but no.
Any other questions? Oh, great. That was really informative, John. I really want to thank you for taking the time today to do this webinar. I really appreciate it, and I think everybody else will do as well.
All right, no worries. Thanks, Chris.
Thanks. Thank you, everyone.
Thanks.
Thank you. It was great.
Thank you.